So we'll move on to the next presentation. Dr. Michaelides is going to present to us on the results of a phase 1/2 trial of an optimized gene therapy in adults and children with retinal dystrophy associated with biallelic variants in RP65.
Thank you very much. It's a real pleasure to be here to share our top-line 6-month data from our optimized gene therapy for RP65 associated retinal dystrophy on behalf of my co-authors and the sponsor Mira GTX. These are my financial disclosures, and those relating to Mira GTX are clearly the most relevant. So there have been multiple phase 1 and phase 2 gene therapy trials for RP65, as there has been a phase 3 trial which has resulted in an approved therapy, Luxturna. And the reason there have been so many clinical trials, gene therapy clinical trials, is that the underlying pathogenesis of RP65 retinopathy is very well understood. There is a large, well-characterized animal model, and there is a very large, broad window of opportunity, both in terms of structure and function. So we've sought to optimize our first-generation UCL gene therapy in terms of increasing its efficacy of transduction, transcription, and translation. And in an RP65 deficient mouse model, we find that this optimized gene therapy is able to restore retinal function at 300 to 1,000-fold lower doses than our first-generation vector. And so we undertook a standard 3+3 dose escalation in adults and then moved to a pediatric expansion phase of 6 children at the 1 × 10^11 dose. Patients older than 3 years were recruited. They had to have evidence of relative photoreceptor preservation on OCT. Primary endpoint was safety, and there were a range of efficacy endpoints, including vision-guided mobility and full-field static perimetry. We sought to deliver the therapy to the central retina, and in the majority of patients, the fovea was also involved with a foveal detachment, and this was undertaken having optimized both vector and the surgical procedure, facilitated by allowing multiple retinotomies and up to a 1 ml volume to be administered. This is an image of the first subject in the low dose, which we'll see subsequently, with the posterior pole fully detached and a foveal detachment with 4 subretinal blebs. This is the overview of the study population, 9 young adults in the dose escalation, 6 children, 2 centers, one in London, Moorfields Eye Hospital, and a second center in Michigan at the Kellogg Eye Center. 3 vitreoretinal surgeons delivered the therapy. In terms of safety, well tolerated with the expected gene therapy safety profile. We did observe inflammation in 3 out of 6 patients in the intermediate and high dose, which was effectively managed by an extension of the steroid cover. And importantly, we did not observe any retinal thinning, including in patients who had a foveal detachment, which was of concern following previous phase 1/2 studies, and also resulted in the phase 3 study not involving foveal detachments. So therefore, based on the efficacy and safety we observed in the dose escalation, we took the 1 × 10^11 dose forward into our pediatric expansion cohort. In terms of efficacy, we saw statistically significant improvements in our vision-guided mobility, both in terms of the overall cohort and also the 1 × 10^11 dose, either combining adults and children or the children alone. And so if you bear with me for this video, this is the first patient tested at the 4 lux level pre-surgery. This is a dedicated facility at UCL in London, sort of more life-size scale mobility, where we actually measure performance by timing how long it takes for the patient to navigate the maze. And then we also look at the errors that the patient made. There's a technician following the patient behind to look out for those errors. So every time you see a little red circle, that's an error where the patient has either touched one of the panels or run their hand along it and brushed against it as they're going to brush now, or if they need to be redirected by the technician behind them, that would also count as an error. So we undertake this starting at 1 lux, up to 5 additional lux levels to up to 256, and we have 8 different configurations, and there's a different configuration per light level. So it's purely a performance of time taken and errors made, rather than looking at a sort of an arbitrary pass-fail type criterion. So eventually this first patient manages to escape the maze, Bear with me, she's nearly escaped the room. Moments away. There we go. So 79.8 seconds, and she makes 16 errors whilst navigating our maze. You're pleased to learn that 6 months later, after intervention, she's able to navigate that maze really far more rapidly and confidently. This is again at the 4 lux level, and you'll see that there's a different configuration here. So she's briskly sauntering through the maze this time. But just as she's escaping, she sort of brushes the side, so makes one error. There we go. So a nice demonstration of the functional effects there can be after a gene therapy. Correlated to that, importantly, we see a statistically significant improvement in retinal sensitivity using full field static perimetry, undertaking advanced modeling of the hill of vision, again here in the entire cohort and the 1 × 10⁻¹1 cohorts. This is just to demonstrate the hill of vision topographically, again in that subject 1, who you've seen the mobility. In the study eye, retinal sensitivity improves from 3 decibel steradian to 3.8 at the 12-month time period, and you see a reduction in the fellow eye of 3.1 to 1.9 decibel steradian. Importantly, we've been also able to demonstrate improvements in foveal-driven visual function at the 6-month time point in our 1 × 10⁻11 dose, both adults and children. So we see improvements in visual acuity, contrast sensitivity, reading speed, and the central 30-degree visual field, which encompasses the posterior pole. So in conclusion, we feel the 1 × 10⁻11 dose is the optimal dose for continued clinical development. We feel that we've demonstrated that subretinal administration, including foveal detachment, importantly is well tolerated and does not result in any retinal thinning as has been previously observed. And we feel our data suggests that our optimized vector improves both functional vision, retinal vision, and most importantly, central vision, which we feel is an unmet need. Thank you very much for your attention.